Welcome back to Navigating Cancer. I'm Dr. Joey Bennett, again joined by Wendy Hall, and today we have a special guest with us, Dr. Torr Carmain. Dr. Carmain is a surgeon at Inverness Surgical Association over in Inverness. New to the community, been here for about 3 months, but comes with an excellent reputation, and I can tell you I've had several patients in common with him already that have dealt with him, and no complaints at all. So welcome to the area.
Well, thank you.
We're talking about colon cancer and colon screenings and everything of this nature because colorectal cancers do kill an awful lot of people. I've got a few statistics here. It's the third leading cause of cancer deaths in this country. It's also the third most common cancer in men and women. It is not selective of sexes. It loves us both. In Florida, as a matter of fact, this year we're expecting 10,200 cases of colon cancer and about 3,300 deaths. So if this is not detected early, people die from this disease. And we've got a great way of detecting early polyps or early changes before they're cancers, and it's the colonoscopy. Tell us a little bit about that.
Colonoscopies, it's been around a long time. Probably about the last 8 or 9 years we've been using for screening pretty exclusively. We used to do a shorter scope called a sigmoidoscopy, which would look at about half the colon. But we've gone to the more longer procedure because we're missing half the colon. Right. And cancers can occur on both sides of the colon. So we've gone to the colonoscopy, and it's the best way to prevent and find cancers early. You can find it in a polyp form before it's cancer and take it out. You've just prevented a cancer. You can find it early when you have a cancer, and now it's easily treated.
And when do you recommend that you start doing these types of screening studies?
If you haven't had one by age 50, you should get one at age 50. That's where most people should start. Okay. If you're at higher risk, if you have a family history or certain other diseases of the colon, you may start earlier. You'd have to talk to your physician about that. But definitely by age 50, you should have one. If you're at higher risk, probably age 40.
And I think one of the things is that, you know, a lot of times people don't like to talk about colorectal cancer. It's not as glamorous as prostate cancer. It's not as glamorous maybe as breast cancer. But it is something that needs to be talked about because it's got to be the most preventable cancer that I can think of us being able to see and screen and to get rid of. And so next we're going to talk about what the colonoscopy risks are, because there is no risk-free assessment of anything. We've talked beforehand about how biopsies sometimes can give you complications, so nothing is risk-free, but colonoscopies are really pretty simple procedures.
They're pretty simple. You basically insert a tube into the colon. The risk would be there's a risk of perforation of the colon. So the colon's a tube, it's got a wall around it. If you put too much pressure, if the pop you take out is too big, there's several reasons that you can perforate, but you can get a hole in the colon. If that does occur, typically we need to have surgery. Right. Not every time.
But I mean, you can see from the slide that's on the screen now, the risk of a perforation or bleeding is extremely low. You know, we probably run a higher risk of a problem driving to work every day than we do with the colonoscopies, especially in Citrus County.
Exactly.
As we go on to the next thing, let's look at the next slide if we could, please. Kind of walk us through, as you can see, where the colon is, kind of give us an idea of the anatomy here, and we can kind of cut back and forth so you can actually show us.
Well, the colon is a big question mark. And it's basically, it starts at the rectum. We insert the scope and we go along the left side, up, across, and all the way down on the right side. And we get all the way to the very tip. And this is where the small bowel enters the colon here. Okay. And the key to colonoscopy is you want to get cleaned out so we can see the inside lining real well. And you want to get all the way to the tip. And a good clean out is essential for that. So when they give you the bowel instructions, follow them and try to get as clean as you can, because that's probably just as important as a colonoscopy itself.
Well, because if you're not cleaned out, then
you can't see the polyps.
And you're going to end up having to clean out again and come back and do it again. So we'll look at the next one. This kind of gives you some more ideas about the procedure. Kind of explain how much time it takes and what people can expect.
It's done as an outpatient. Typically, you need to take off 1 day of work. The bowel prep that's done the day before can easily be completed at night the day before. So you don't have to miss any work beforehand, and then you can be back to work the next day. Typically what occurs is you'll get some type of bowel prep, and there's several different types depending what your physician likes. But you'll get the instructions for that. You'll probably stay in clear liquids that entire day, and then that night do the prep where you get a clean out. Right. Then you'll come in the next day, they'll put an IV in your hand, they'll sedate you for the procedure, and you basically go into a twilight sleep. You typically don't remember too much of that. You can't remember bits and pieces, but you're not completely asleep.
Now, if I want to stay awake and watch the TV screen, how much discomfort am I in?
It varies. Some people have no discomfort. and other people have lots of discomfort. When I had my colonoscopy, I tried to stay awake, and I had lots of discomfort, and I got put to sleep.
You told them to put you to sleep. So, and the reason that you want to take a day off is the light sedation that you have.
Right, you can't operate a motor vehicle, you can't drive yourself home, and you're going to be crampy. You'll go home, take a nap. When you wake up at night, you'll feel pretty good, and you're ready for work the next day.
Right, and I mean, you would have to have somebody bring you in for the test, someone to drive you home, because we certainly don't want you going out and driving with the anesthesia. Procedure takes basically...
The procedure itself takes about a half an hour, but I always tell people door to door is about 3 hours. So you come in, you got to get about an hour prep time, get the IV and get you ready to go. Do a half an hour of the procedure, then you have to recover for an hour to an hour and a half, sometimes less, and then you're ready to go.
And just basically whenever they feel like you're comfortable and safe enough to go home, then you can go ahead and go home and finish the sleep.
Absolutely.
There, good. So look at the next one. It gives you an idea of, we're not just looking for colon cancers when colonoscopies are done. You know, the surgeons or the gastroenterologist are looking for several different things. So it can be done for things just other than polyps.
Right. If you have rectal bleeding, you might find diverticulosis, you may find angiodysplasias, you may find other things. But the typical things that we typically find would be polyps. Probably half the time we find those. And we commonly see diverticulosis, which is not alarming. I would say at age 50, 50% of people have some diverticulosis. So that's something you may hear. It's not an alarming thing, and you may hear that, but that's not increased risk for cancer.
Yeah, diverticulosis is kind of having an outpouch on the intestine that can get inflamed and irritated. When that happens, it's diverticulitis. And for those of you who are watching who may have that, you know that you don't eat peanuts, you don't eat strawberries. There's certain things you avoid.
Well, actually, now they say you can.
See, the program is worthwhile. So, because I've got several friends that have diverticulitis, and one of them works at our office, Wes, and every once in a while he'll reach and grab some peanuts and forget, and it's too late. So,
if you think the peanuts cause a problem, avoid them. But if you eat, I mean, seeds are in so many good foods.
Right.
We don't want to avoid those. So
which you want to try to eat healthy, right?
Right.
So, next slide, we kind of get an idea of what it is that you're actually seeing, and these are some actual photos that Dr. Carmain brought with him. Showing what polyps look like. Kind of describe what we're seeing.
What you're seeing is an outgrowth of the mucosa, because that's where polyps form. And you can kind of see these, it kind of looks like a little brain, actually, when you look at it up real closely. And these are both polyps that could be taken off during the scope. They could put a little snare around those, burn those off, and then we collect the tissue and send it to the pathologist. These both look benign, but certainly these are the size polyps that you get a little bit concerned about, that it could be early signs of cancer developing if they're not removed.
And so now that we've had the colonoscopy and we've seen the polyps and removed them, what happens if we find a colon cancer? We'll talk about that right after this.